just checking. I just wanted to see if it was. Oh yeah, live. Look, that looks great. Boom. Perfect. It's just the internet.
All right. Ready to rock and roll for our afternoon session?
We're ready, Dr. Hildebrand.
Oh my gosh, Dr. Powell, thank you, sir. Hopefully Health Plaza is ready to rock and roll as well. I trust that Dr. Sutherland gathered you all together. All right, we are more than halfway done. That's incredible. So up next, we will be hearing from Dr. Cho. And any other issues, or everyone had a good lunch? Everyone's great. Oh, Taziki's Health Plaza.
Ooh.
Yeah.
What?
That's right.
I should have stayed.
You should have stayed at Health Plaza. Thanks for the Chick-fil-A, it's delicious.
Yeah, okay.
All right, Dr. Cho, please welcome her.
Hi, I'm Scarlett Cho, the current PTY2, and my advisor is Dr. Williston. My topic today is maternal caffeine intake associated with behavioral disorders in offspring. So start with a little background. So caffeine is the most common stimulant in the world, and it is an antagonist of the adenosine receptor. By increasing the release of neurotransmitter, it stimulates the neural system, increase the alertness, but it is also associated with anxiety, depression, insomnia, and other kind of mental psychiatric disorder. During the pregnancy, caffeine crosses placenta and it further crosses fetal blood-brain barrier. It is metabolized slower during the pregnancy and even slower in fetus. So could caffeine possibly correlate the pregnancy and psychiatric disorder? So my question actually comes from my life. Before I came to the United States, I seldom drink coffee. So I just kind of wondering what it changed my life, but just to clarify, I'm not pregnant.
How's the anxiety?
So my CME question, 30-year-old female resident physician got used to drinking coffee during her busy residency training. She's married and plans to have kids. She knows that caffeine could increase anxiety. So what if she gets pregnant? Will that affect the baby? Can she still drink coffee while she works in the hospital?
Your questions reflect your anxiety, sorry.
So A, it will cause some behavioral disorder in offspring, so she should not drink any. B, it may potentially cause behavioral disorder in offspring, but only if it's a large dose. A cup of coffee a day is probably fine. C, there's no relationship, so you can drink as much as you like. D, there's no evidence of any relationship, so we cannot give any recommendation on that. Want to take any guess? So I got 3 studies here. The first study is a Danish study that recruited about 47,000 children. And the maternal caffeine consumption during pregnancy was reviewed at 15 and 30 weeks of gestational age and categorized into 4 groups. And behavioral disorder was evaluated by the Strength and Difficulties Questionnaire, which is a screening tool, when the children were 11 years old. And this study take 3 different outcomes, including conduct oppositional disorder, hyperactivity, inattention disorders, and anxiety depressive disorder. Also measure some covariance and calculate the risk ratio. And it also adjusted total daily caffeine consumption to observe the trend. So this is a descriptive statistic of the study. It's a really large table. I just include part of it. So about 12% of people drink more than 4 cups of coffee a day. And one thing interesting is that maternal smoking and social classes were associated with caffeine intake. Those women who drink more than 8 cups of coffee a day also tend to have cigarettes. But after stratification, they didn't actually statistically affect the results. And there's about more than 6,000 cases of any psychiatric disorder. So the first one is the anxiety depressive disorder. So, okay, drinking more than 8 cups of tea a day is, in first trimester, was associated with a higher risk. However, while coffee actually has more caffeine in it, it didn't find a similar effect. So they assume that it's probably something else in the tea that caused this effect. And when they studied the caffeine dosage as a continuous variable, the caffeine dosage is not associated with an increased risk. The second disease is conduct oppositional disorder. Drinking coffee and tea more than 8 cups a day were associated with an increased risk, and that's also in first trimester. When they studied the caffeine dosage as a continuous variable, they still did not find a significant increased risk. However, they found a dip over here. This means when the mother drink small amount of caffeine actually has a decreased risk. However, they think this is not because of the protective effects of caffeine. They found that those women who didn't drink coffee or tea at all tend to drink more soft drink. So they are guessing that's probably why the reason. So for hyperactivity and attention disorder, drinking more than 8 cups of coffee and tea a day in first trimester were associated with increased risk. And this p-value here indicates when they study the caffeine dosage as a continuous variable. Increased caffeine dosage is actually associated with an increased risk, and this is statistically significant. There's also a dip found here. And for any psychiatric disorder, the result is similar as the one with conduct oppositional disorder. So conclusion for study 1 is that maternal caffeine consumption at high dosage was associated with behavioral disorders in offspring. They found the effects only in first trimester, which may be explained by the development of fetal brain and at early gestation. So this is a picture of me going to Malawi last year. And then study 2 is a Norwegian study that recruited about 25,000 cases, and maternal caffeine consumption was reviewed at 17 and 30 gestational weeks by questionnaire and also categorized into 4 groups. Children's inattention and overactivity was measured by child behavioral checklist at 18 months. This is a screening tool with a lot of questions, but they only took 5 of the questions that is related to inattention and overactivity. So they analyzed the data by ANCOVA, which is a model to stratify the covariance. So they have 3 models. First model, they adjust for gender only, and second model, they adjust gender and maternal characteristics. Model 3 adjusts for above plus the neonatal characteristics. So the results show that maternal caffeine consumption at 17 gestational weeks was associated with an increased risk, even after adjust for the confounders. But when they study the overactivity and inattention separately, the effect remained only in overactivity. And maternal caffeine consumption at 30 gestational weeks, they found that only overactivity was related to the maternal caffeine consumption. Interestingly, they further studied different sources of caffeine, and they found that the effect was only found in soft drink, not in tea or coffee. So conclusion, there was a small effect of maternal caffeine intake at early gestational age on offspring inattention overactivity. However, this effect was only found in soft drink. Study 3 is also a Danish study that recruited about 24,000 cases, and the questionnaires were filled out at 60 gestational weeks. to measure the maternal caffeine consumption. And different from the first two studies, this study, they directly obtained the cases of hyperkinetic disorder and ADHD from a psychiatric central register, which were those cases that were confirmed cases. And because they obtained those cases in the same year, 2002, those children were ranging from 3 to 12 years old. So we know that age can affect the diagnosis, so they use the Cox regression to analyze, to take time into account. So they have total ATA positive cases. And drinking more maternal caffeine consumption for more than 10 cups a day was associated with an increased risk. However, after they adjust for the confounder, the effect no longer exists. They also analyzed the different sources of caffeine, including soft drink and chocolate, but the results were similar as coffee alone. So conclusion is that drinking more than 10 cups of coffee a day in pregnancy was associated with an increased risk of offspring ADHD and hyperkinetic disorder. But after adjusting by confounders, it showed no statistical significance. So I compared the three studies. Study 1 has the largest sample size, also more positive cases. However, study 1 used a screening tool, while study 3 used a diagnostic tool. So there were pros and cons in each scenario. And in study 1, they studied the children when they were 11 years old, which was able to predict the long-term outcome better. And study 3 didn't study the late pregnancy, but in study 1 and 2, we know that maternal caffeine consumption at 30 gestational age didn't really affect the childhood behavioral disorder. And study 1 studied the most broad spectrum of psychiatric disorder. And they all adjusted for many confounders. In study 2, it further adjusts for the neonatal characteristics, but it didn't affect the result. And study 3 also further adjusted for parental and sibling psychiatric hospitalization, but they found that the result was similar, like if they didn't put that into account. So all the study adjusted for caffeine sources, but for study 1, they only observed some relation with the soft drink. They didn't actually calculate the total caffeine in soft drink. While study 2 and study 3, they did calculate soft drink into it, but they have different results. And this is how they categorize the caffeine dosage, and only study 1 has studied the caffeine dosage as a continuous variable, and these are the way that how they calculate the caffeine dosage. So I put a conclusion here again. There were some limitations of this study. First of all, we know that it's not possible to accurately estimate the caffeine consumption. But I think practically speaking, when we tell our patient what to do, we probably say like, hey, no more than 1 cup of coffee a day, and a small cup, not espresso. And And also the second limitation is that there's different sources of caffeine and other components in them. And third is that there were other confounders, for example, races, the popular topic. So for answer for my CME question, I would give B. it may potentially cause behavioral disorders in offspring, but only if it's a large dose. A cup of coffee a day is probably fine. But not just mental psychiatric disorder, there may be other things. Some other potential outcome is that maternal caffeine intake slightly increase the risk of congenital anomaly, childhood overweight, or like low birth weights, even though those data were probably not like insufficient or not very consistent. So what should we tell our patient? So currently the general recommendation is pregnant women should limit their caffeine consumption to less than 200 to 300 milligrams a day. And on UpToDate, there's tables with different drinks and their estimated caffeine dosage. And don't forget about like chocolate and soft drink, because those had caffeine in it as well. Thank you. Any question? Yes.
Do you think that the behavior assessment was sensitive enough to show the changes you were looking for?
Sorry, can you repeat it?
Do you think that the tools that they used to assess the behavior in the offspring was sensitive enough to detect the changes that you were looking for?
So Dr. Rylander was asking that whether those tools is sensitive enough to relate with the change that I'm looking for. So I think for the first study, the tool will be more sensitive as they identify more positive cases. But in the third one, it's not as sensitive. Yes.
I mean, this doesn't have a whole lot to do with your research question, but did they comment on perinatal withdrawal from the women that were using huge amounts of caffeine? You know, like we do for nicotine or other addictive substances?
So Dr. Carroll is asking about perinatal withdrawal, if those were mentioned in this article. No, they didn't mention about that.
Looking at these studies, and I guess particularly the third study, when they had were able to compare the different confounders. It's not pertinent to your question, but did you see anything that had a more significant effect for this outcome, more than caffeine, like whether it was the parental years of schooling or employment status, cohabitant status? Were they able to draw out, because I know you were specifically looking at caffeine, but I'm just out of curiosity with that study, did they show those other factors having any larger impact, or,
Yeah.
or were they just saying it's confounders?
So Dr. Ganser was asking about these confounders, whether these confounders can actually have impact on the disorder. So yes, they especially in study 1, they specifically mentioned that smoking can be a risk to have like childhood ADHD or other psychiatric disorder.
Sorry.
It's from the Health Plaza. What are your thoughts on the observation that soft drinks may have had more of an effect in relation to sugar intake?
Well, that is a good question, I think. There will be some more. There will be some more study too.
It's a good advent for next year.
How big of a change would you have had to show to be able to successfully get women to stop?
I think, I mean, those are huge.
Sorry, I
Yes.
Is somebody, after drinking that much coffee.
Hi everyone. Hello. I am Babita George, second year with I.H.I, and my topic is on effective ambulation or walking during labor. So I'm going straight away to the background on how I arrived at my question and why. So back home where I'm from in India, it was common practice for me to see pregnant ladies walking the hallways, laboring, while they are laboring. And there will be family members, mainly ladies, helping and encouraging the women in labor, to keep up the walking. And walking was a go-to intervention when it came to anything with regard to labor, be it the descent of fetal head, be it management of pain associated with labor, or even progression of labor. And in some of the hospitals, mainly mission hospitals, I've seen ropes that are being hung from the ceiling onto which the women can grab on or hold on to while they take breaks in between uterine contractions. So from such a background, I came to this, and I mean, it was, to me, it was really perplexing as to why women are tethered down. Kind of reminded me of how being tied up, and so I was wondering if that was so perplexing to me, then how much it is being effective in a lady's mindset when she is in labor. So that brought me to my question. Does ambulation during labor reduce duration of labor and the rate of C-sections? These are the various options in terms of answers that I have put up. You can take your guesses, and we will arrive at the answer towards the end. So to briefly go over the anatomy of upright positions versus recumbent or lying down positions. So in the first picture, you see a woman standing upright, and in that first, can you see the first? Okay, so in the first position, you can see that the route that the baby has to take is a right angle turn directly and then go straight down. And if you tilt that first picture to a 45-degree forward angle, it's the same route that the baby has to take if the woman were standing up. And in the last picture, that is if you tilt the picture to a 90-degree, you see that you simulate a mom on her back, and this changes the dynamics. All of a sudden, the mom will have to push the baby up an inclined plane and against gravity, and it is evidently exhausting. So how does ambulation actually work? Gravity plays a big role. It helps in the descent of the fetal head into the pelvis. And when the head is applied directly and evenly onto the cervix, it is at this point that, which helps the cervix in having effective dilation and progression of the labor. And the effective uterine contractions will eventually help in, delivering the baby. And also, ambulation or walking is a good distraction for the mom, and it gives the mom something to think about while she is in labor, and also it decreases the need for analgesia. Whereas lying down, this has shown, and studies have shown that this negatively affects the strength of contractions. And Another thing that I found significant was it can even, standing up from a supine position can even often reverse the negative effects that, lying down could have had on the uterine contractions. And as all of us know, lying down, the gravid uterus can push down on the abdominal blood vessels, thereby negatively, impacting the blood supply to the uterus and then to the baby. So if women are given the opportunity, they may choose to be in an upright or ambulant position during the first stage or early stage of their labor, and eventually can even choose to lie down as their labor progresses. So why is it important to do this review? As care providers, we all know that lying down or recumbent positions are convenient for all of us because it gives easy access to the mom, be it in terms of uterine palpation, monitoring the baby, with having all the leads on, doing cervical examinations. So lying down is a good position for all of us. When the patient is lying down, not one of us. And the development in technology also has made a big shift in the change of care that is being provided, mainly in terms of technology and when it is continuous electronic field monitoring that we are doing for all of our patients nowadays. And epidural anesthesia and IV infusions, all of this will require the women to be on her back all the time. So it is important to assess the available evidence that we have so that maternal positions which are shown to be safe and effective during the first stage of labor are actively encouraged. And also we need to be able to give clear, consistent, and evidence-based explanations so that women will be able to make informed decisions about the positions that they choose when they are in labor. So in the quest of my, in search of the answer to my question, the first study that I have included is a Cochrane review. It's a meta-analysis done in 2013 titled Maternal Positions and Mobility During the First Stage of Labor. So the background of this study is, even they mentioned that this is very convenient to the staff, and I saw that they've included this pertinent snippet. They've observed that in the cultures that are influenced by the Western society, in the first stage of labor, women adopt upright positions and change positions as they wish, with no evidence of harmful effects. Sorry, cultures that are not influenced by the Western society. And in developed nations, they say that women do that if they're encouraged. So the objectives of the study is, I'll read the first sentence, to assess the effects of different upright and recumbent positions for women in the first stage of labor on duration of labor, type of birth, and other important neonatal and maternal outcomes. So this was the objective of the study, and I was happy that the study included both parts of my question. And their primary objective was to compare the effects of upright versus recumbent positions in the outcomes of the labor. And there were multiple secondary objectives. I have highlighted the first two, which are pertinent to my question, which is specific to walking. And they classified the upright positions to be walking, sitting, standing, kneeling, squatting, and being on all fours. The recumbent positions that they referred to were supine, semi-recumbent, and lateral. Basically anything that is not upright. The methods that they used were, so they included 25 randomized controlled trials from 13 different countries, and all these studies spanned over 50 years from 1963 to 2012, and there were 5,218 women included in the study, and they were all in their first stage of labor. And majority of the trials included nulliparous singleton pregnancies, women greater than 36 weeks gestational age, which they were either spontaneous or induced to have their labor. And none of them had obstetric or medical complications. So the interventions that they applied was, ambulation and being recommended during their labor. And the primary maternal outcomes that they measured were duration of the first stage of labor, mode of birth, that is whether it was vaginal, C-section, or operative deliveries. There were other outcomes as well, but then again, these were the ones that are pertinent to my question. Limitations of the study. Blinding obviously was not feasible for the patients nor for the care providers. Time of ambulation and upright positions varied across all the studies because, as I mentioned before, this was a meta-analysis which included different countries over a large span of time, and there were a number of different healthcare settings and also cultural differences in the expectation of how labor should go and expectation of management of pain during labor. There were a lot of variabilities as is expected when it comes to something as common as pregnancy and labor. So what they did was they divided they divided the women into two groups because epidural and not having epidural played a big role. So the first group, they named it as group 1. They were the ones who did not receive epidural. And the second group, they classified them as who did not receive epidural. And they further did sub-analysis among each group. That is, they measured the outcomes of walking separately, sitting, squatting, all four separately within each group. And, sorry, this came out wrong? Yeah, and the outcomes that they measured were the same in each groups. So these are the results. So in group 1, without epidural, in an overall analysis, that is all upright positions versus recumbent positions, they found out that the first stage of labor shortened by approximately 1 hour and 22 minutes, and the rate of C-section decreased by almost 30%. And under subgroup analysis, which looked into only walking versus a recumbent position, the first stage of labor was shortened by approximately 3 hours and 57 minutes, that is almost 4 hours. And the C-section rate was lowered by almost 70%. In group 2, who received epidural, the duration of first stage of labor could not be assessed because of the variability in recording of data, because some of the studies, they recorded the first stage starting from when they received the epidural and they also recorded the end of labor as a different time set. That is, some recorded it as 10 centimeter cervical dilatation, some recorded it as delivery, the time of delivery as the end of second stage. So there was a lot of variability in recording what was exactly the first stage of labor. And under subgroup analysis, they showed no difference in the modes of deliveries in upright or recumbent positions. So the conclusion that this meta-analysis brought about was there was clear and important evidence that walking and upright positions in the first stage of labor reduced duration of labor, reduced the risk of C-sections, reduced the need for epidural, and it was not associated with increased intervention or negative effects on moms or babies. They also go on to mention that better quality trials are required because of all the variabilities in data gathering and the differences that are involved culturally. And also they mentioned that it is worthwhile that women are informed about the low risk, women in low risk labor should be informed about the benefits of upright positions. The second study that I included was a randomized controlled trial titled Effectiveness of Ambulation During the First Stage of Labor on the Outcome of Labor among primary gravida women. And this study was done from the state that I hail from in India. They also had multiple objectives. I circled the one that is pertinent to my question. They also, one of the objectives was to find the effectiveness of ambulation during the first stage of labor in terms of maternal outcome. So they measured the duration of labor and the mode of delivery. I could include the study only to answer the first part of my question, that is the duration of labor, because they did not mention anything about a C-section. They did not include any of the ladies who got C-sections in the study. So this was a randomized controlled trial done in 2015. This included 60 primary gravida women, and they took lots. They mentioned it as a CHIT method, and they included women into two groups: the experimental group, which ambulated, and the control group who did not ambulate. And the limitation of the study they mentioned was that they could not do perfect matching of the samples between two groups. The intervention that they did was, for the experimental group, they allowed the women to ambulate for 1 to 1.5 hours during their labor, And for the control group, they were confined to bed most of the time. They used Partograph, which is a standardized charting tool that is used by WHO to record the progress of labor, and they recorded the outcome of the labor as well. So the results, this study showed that the mean duration of labor in the experimental group who walked was lower than that of the control group, with a mean difference of duration of labor by approximately 42 minutes. And this was the conclusion, that ambulation during first stage of labor was effective in reducing the duration of labor among primary gravid women. The third study is a retrospective cohort study done in '97, titled Relationship of Ambulation in Labor to Operative Delivery. So I included this study to answer the second part of my question, which is whether ambulation will decrease the rate of C-section. So the methods, it is a retrospective cohort done in '97 over a 12-month time period. It included 3 practices in the United States, and all the women included in the study received only nurse midwifery services. It included women, 1,678 women. They were all healthy, term gestation, singleton pregnancy, vertex presentation, spontaneous labor without any prenatal complications. None of them received epidural or augmentation or oxytocin during their labor induction. And they defined operative delivery as either C-sections, vacuum, or forceps extractions. And their intervention was they allowed women to ambulate to facilitate labor, and they included women who could ambulate for at least half of their labor in their study. And the limitation of the study was they did not specifically mention the rate of C-section. They included the C-section, vacuum, and forceps delivery all together as one result. And the result was the rate of operative delivery was reduced by approximately 50% among women who ambulated versus those who did not. And I thought this was interesting that women on Medicaid program were more likely to ambulate. And the conclusion of the study was ambulation during labor reduces risk of operative delivery. And I.H.I. in 2019 had a committee opinion titled Approaches to Limit Intervention During Labor and Birth, mentions this as part of their study, part of their opinion. Frequent position changes, including ambulation, that help with maternal comfort and optimization of fetal positioning can be supported during labor as long as adequate monitoring of mother and baby can be performed. And in order to facilitate that, they encourage providers to do intermittent auscultation and non-pharmacologic methods of pain relief. And to enable them to do that, they encourage considering adopting protocols and training staff to use handheld Doppler devices. And they've also mentioned that continuous electronic fetal monitoring has no significant effect on outcomes such as perinatal death and cerebral palsy in low-risk pregnancies. Small picture break, this was the time when we went to Togo, myself and my husband, and this is a small church that we could help plant within the hospital that we visited, and they're still meeting up to this date. So I come to the final moment. Does ambulation during labor reduce duration of labor and rate of C-sections? The answer is yes, it reduces both duration of labor and rate of C-sections. So I thought it's interesting to put up a little stats. So in the United States, the C-section rate currently is 31.9%, and the global rate of C-section is 21%. And there are countries like Sweden who has the lowest C-section rate to be 17.3%, and they have one of the lowest maternal mortality rate. WHO considers ideal C-section rate to be 10 to 15%, and they also mentioned that greater than 10% is not associated with reductions in maternal and newborn deaths. So what now, what can we do if we have this as the answer to the question? So I personally think that women should be informed about the benefits of upright positions, and at least be given the option to choose to be ambulant when they are in their, at least in their first stage of labor. And they should be, given that freedom of movement options, especially when WHO also has recommendation on how to do intermittent auscultation, and maybe even think of wireless fetal monitoring system. I talked to a couple of friends of mine who are in India. In some of the mission hospitals, they even have Wi-Fi CTG, and that seems to be working well. So why can't we do it here? So I leave you with that, and thank you, Dr. Ledbetter, for helping me with this excellent topic, and Dr. Hillerman and Dr. Rylander. Yeah, questions? Yes.
Okay, I have a question from the Health Plaza, but first a comment.
Yes.
For anyone who's interested in this, I really encourage you to read the Labor Progress Handbook by Penny Simpkin, who's a 25 nurse midwife with decades of experience, and it's a really great book. Okay, question from Health Plaza. Did they control for support people like doulas during labor in these studies? We know support people can help with outcomes in labor, and often people who do have labor in upright positions have doulas, so this could be a confounding factor.
So the first study especially, they mentioned about doulas being used, but then that was not going to be a confounding factor because women are walking. I mean, it doesn't matter how they got them to walk, but they walked. So if we get them to walk, that's what it mattered for this. Yes, Dr. Donick.
In your opinion, what are the biggest roadblocks to us implementing this at the hospital we deliver?
Ooh. So this is Dr. Donick's question. He asked me what, in my opinion, what are the biggest roadblocks in us implementing this in our practice? Again, my personal observation, I think us care providers are the first roadblock. That's my opinion. I mean, we have to get this idea wrapped around our mind first, that this is something that we can encourage women to do, and educating other care providers, like the nursing staff as well, to encourage women to do this. And yeah, it's us, I should say. That's the biggest roadblock in our mentality.
I think you're 100% right, because I think we always blame the nurses, and I think we need to look at ourselves. I've yet to have a time when I really pushed for a patient to ambulate that the nurse didn't go along with it. Even though they didn't really want it, they did it. So I think we're the problem. We don't teach them that this is good, it's safe. We don't talk to our patients during antenatal care that this is what will happen in the hospital. You're low risk, you will walk. It's about expectations, and then we just can go sit in the report room and watch the monitor, and we're golden. And it's obviously not the best care.
Is anesthesia down with walking epidurals though? Because a lot of women want epidurals, but they don't want to do that.
Well, and that's an education too. We talked about non-pharmacological methods or other methods of pain management. Laying in bed is worse than anything.
Yeah, it's always the same.
Like 6 hours.
Thank you. Hi everyone, I'm Rebecca, and I think I'm the one to round off the third of these, like before our break, and it's another OB topic, so yay. My presentation is about whether myo-inositol supplementation during pregnancy reduces the incidence of gestational diabetes. So let's get started. And my evidence-based answer is that yes, oral supplementation with 2 grams of myo-inositol twice daily during pregnancy is associated with lower rates of gestational diabetes. So to start off, let's talk about what are inositols, because I didn't know about them before I did this research project. And so inositols are a family of simple carbohydrates that you can find in cereals, legumes, and fruits. They're part of the cellular membrane, and they help regulate mitochondrial function and different hormonal signaling in the human body. And so inositols increase insulin sensitivity in the body. And the 2 of the most common isomers of inositols are myo-inositol and D-chiroinositol. These are the 2 that we're going to focus on mostly during this presentation. So just as a little key, whenever I'm referring to inositol or inositols, it's referring to either myo-inositol or D-chiroinositol. MI stands for myo-inositol and DCI stands for D-chiroinositol only. All right, so then the next question is also, what is gestational diabetes? So the definition is glucose intolerance during pregnancy in women without chronic diabetes. So there are some normal changes that happen during pregnancy that allow for the woman's body to have increased resistance to insulin, because that allows for more glucose to go to the fetus to allow for growth and development. Gestational diabetes happens when there's too much insulin resistance, so then there's too much glucose that remains in mom's system, and she has high sugars, so she gets diabetes. And we know that gestational diabetes can cause a lot of complications. I've listed some here, but we can see that this increases risk for both mom and baby, and not just during pregnancy or in the postpartum period, but moms can even continue to have type 2 diabetes for the rest of their lives. So if we can find something to help reduce this, that would be awesome. Interestingly enough, even though we know that it causes a lot of harm and we see a lot of patients with it, I'm sure all of us have treated someone with gestational diabetes, there's not yet consensus on how to diagnose or even treat gestational diabetes. So I wanted to talk a little bit about the diagnosis of GDM. And there are 2 kind of main criteria. The first set here is the one that we use. So basically moms at 24 to 28 weeks of gestation will have a 1-hour glucose tolerance test. And if that's abnormal, then they go to a 3-hour test. And if 2 or more of those values are abnormal, they're diagnosed with diabetes. But there's actually a different criteria set by the International Association of Diabetes and Pregnancy Study Groups. And they will have their moms check a fasting sugar during the first trimester. And if that sugar is between 92 to 125, they're automatically diagnosed with gestational diabetes. If it's lower than that, then they are go to the second phase, which is during the 24 to 28 weeks of gestation, they'll do a 2-hour oral glucose tolerance test. And if any one of those values is abnormal, they also get the diagnosis. So both of the studies that we're going to talk about today are actually using the second criteria, or a form of that one. And you can see that that one's a little bit more strict, right? You can diagnose gestational diabetes with less, I guess, it's how do I say this? Less of a range, or it allows for less glucose. You can diagnose it earlier, and the glucose values are a little more strict. So the numbers themselves, well, a lower glucose can allow you to have that diagnosis. So let's go to study number 1, which is a meta-analysis. And this was completed in 2019, where it included 5 randomized controlled trials, and there were 3 different regimens that were looked. So 3 of the studies had a comparison between 2 grams of myo-inositol twice daily versus placebo. One study had a combination of myo-inositol and D-chiroinositol versus placebo. And the last study also had that combination, but at different dosages, and manganese versus placebo. 4 of the studies were done in Italy and 1 was in Ireland. The total number of participants was 965, and the inclusion criteria were different among the various studies, but 4 of them had the requirement that the women had to have singleton pregnancies, so not twins or more. 2 other ones required that the participants had a first-degree relative with type 2 diabetes. Some of them also had certain BMI range requirements. And so the intervention that was done was basically starting inositol at 10 weeks to 24 weeks of gestational age. And the primary outcome that the meta-analysis looked at was the rate of gestational diabetes in patients receiving supplementation with inositol. And the result was that there was a significant reduction in gestational diabetes with the supplementation. So a total of 848 participants, and it boils down to that the risk of GDM without the supplementation was 227 per 1,000. The risk for GDM with supplementation was only 126 per 1,000. And then they also had a lot of other secondary outcomes that they looked at, including lipids and whether inositol affected the lipids, and we can see that those the lipids listed there were reduced at the 60-day mark. There was a reduced fasting value on the 2-hour glucose tolerance test, and the number of preterm deliveries were also reduced. However, there were a lot of secondary outcomes where there wasn't a difference between the groups that received inositol versus control. So you can see the number of people included for each of those outcomes, and some of these outcomes are the ones that are the dangerous ones that we want to try to prevent. And so, fortunately, it didn't help with inositol didn't seem to help with any of these. Then they did a further subgroup analysis that specifically looked at whether just myo-inositol by itself versus the combination of myo-inositol and D-chiroinositol made a difference on the rate of GDM. And it did show that the treatment with 2 grams of myo-inositol twice daily was more significant. So the benefits, the benefits that I did mention earlier, and then 2 slides before this, with the reduced fasting blood sugar, the reduced rate of preterm delivery, were significantly different in the myo-inositol only group when they separated them out, and not so much in the D-chiroinositol. You can see by the numbers here, the rate of gestational diabetes among those that had the combination actually was a little higher than the control when you add it all together. So that suggested that it was the regimen of 4 grams total myo-inositol daily that really made the difference in these studies. And my second study was a randomized controlled trial, which was published in 2018. It started, the study itself started in January of 2012 and went to July of 2017. It included 157 participants, and all of these women had singleton pregnancies, and they qualified for the study if they're elevated, or if their fasting sugar in the first trimester or early second trimester was elevated. So if you remember that second column of the criteria, it was that first arm where they were positive. So for this study, they weren't labeled as having gestational diabetes just based on that value, but that's how they collected their participants, and then those participants were referred to high-risk pregnancy center in Italy where the study was conducted, and they went through that second stage to where they did the 2 grams oral, the 2-hour oral glucose tolerance test to determine whether they actually had gestational diabetes or not, or that label. Of note, exclusion criteria on this one was a BMI greater than 35, pre-gestational diabetes, and age less than 18. So all of the participants were given nutrition and exercise counseling. They were all encouraged during the regular OB visits to stick to their treatment program, and also they were asked about whether they were taking any other vitamins or medicines or dietary supplements. And these were the 4 different groups that were studied. So again, the myo-inositol only group, D-chiroinositol only group, the combination group, and then the control group that only got like folic acid. Compliance was defined as 80% or more of therapy taken during the pregnancy. And then the dosages that were selected here were based on previous studies evaluating insulin resistance in GDM. All right, so the primary outcome here was whether there was an abnormal 2-hour glucose tolerance test. And you can see that the myo-inositol only group was the one that had the lowest, and it was significant, with the number needed to treat of just 1.773, and significantly lower than some of the other arms. There were also some secondary outcomes evaluated in this study, and I've listed some of the ones that were showed that inositol supplementation did make a difference. So myo-inositol, in the myo-inositol only group, there was a higher gestational age at birth. There was a smaller fetal abdominal circumference percentile, and the incidence of neonatal hypoglycemia was actually 0% in that group. So 9 out of the 39 newborns had hypoglycemia. And so this suggests that the moms that did take myo-inositol, 2 grams BID, had good metabolic glucose control because they delivered at a later gestational age, and their newborns also didn't have hypoglycemia, which is a great thing that we wanted to prevent. But again, there were other secondary outcomes like pregnancy-induced hypertension and others that can, like preterm delivery, that were not significantly different in this study. So whenever we're talking about pregnancy, we also wonder whether any medicines are safe to take during pregnancy. And although I didn't see any information on whether there were any negative effects on baby, so any risk of harm to baby because of supplementation with myo-inositol, all of the women that participated, so over 500 women, said that they had no personal adverse side effects from the supplementation, which is encouraging, that it didn't cause any additional difficulty to mom. So would these studies cause me to make any changes in my clinical practice? A couple of thoughts came to mind, and one was whether we should consider using the second criteria for diagnosing gestational diabetes instead of the one that we're already using, because it picks up persons that might be at risk for gestational diabetes earlier by using that fasting glucose screen in the first trimester instead of waiting to 24 to 28 weeks, and also a little bit of a stricter glucose control goal. And then if we are able to use the second criteria, maybe we can identify those persons that are at increased risk in addition to their family history or other comorbidities that might predispose them to getting gestational diabetes, and consider starting those persons on the regimen of 2 grams of myo-inositol BID during their pregnancy. These are my references. And thank you to Dr. Gruhl as my preceptor, and Dr. Hildebrand and Rylander for helping. Any questions? Yes, Dr. Hildebrand.
Do you know how many more false positives would occur with the second set of criteria? If it's more sensitive, it's going to pick up more false positives, and then what effect does it have on those false positives for us to treat them as if they have gestational diabetes?
Yeah, so Dr. Ledbetter is asking about if I know about how many more false positives we would have, and then how would that affect how we're treating those persons with the false positive results. So I think in terms, I don't know exactly how many more would test as having gestational diabetes and not actually having it, but my thoughts are that myo-inositol doesn't seem to cause negative adverse side effects to mom, and then the supplement itself we don't know so much about babies, but it doesn't seem like it would do additional harm, even if they didn't have gestational diabetes. And then, but certainly having that diagnosis later on in the pregnancy would lead to more prenatal visits in terms of antenatal testing, possible induction earlier, and complications there. And so have to weigh in those things. Yes, Dr. Carroll?
When they were doing the study, if a woman flipped over and became diabetic, did they keep them on the inositol or these other interventions, or did they take them off, did they say?
So if they did, the question was whether if one of the moms became diabetic during the study, would they take them off the inositol or not? I think there were, in the second study, I think they did, and I'd have to go back to look specifically, but they didn't have, I think they encouraged them to continue the treatment because the outcome was whether, the primary outcome was whether they developed it or not, regardless of what, across all of the treatment arms. So I think everyone was, intent to treat, I think was the term that was used. Here, I can go back real quick, I think I have that written in. Basically, if they did have it, like that was part of the outcome. So it was a non-inferiority trial test. And so I don't think that they changed it based on that. Yes, Dr. Rylander?
When you compare using the two different criteria, how would you decide if that group was a false positive or a false negative that you caught?
If I'm comparing the two criteria.
When you compare the two criteria, there's a group of patients that would be treated using the second criteria that would not be treated using the first criteria. How would you determine whether that group of patients were a false negative from the first criteria or a false positive from the second criteria?
I think Dr. Rylander is asking how I would determine whether there was a false positive or a false negative based on the different criteria. I'm not sure I'm understanding correctly, but I don't know. Yeah, I'm not sure. Sorry, Dr. Rylander.
So the other way of asking it is, have you all in your clinical practice seen babies that were too large born to people that you go back and look at, and you say they must have failed their glucose tolerance test, and you say, oh no, they passed their glucose tolerance test, but the baby's 8.5 pounds.
Mm-hmm. Yeah, so Dr. Rylander clarified that, so if, for example, we used one criteria and a baby weighed a lot, but their glucose tolerance test was actually negative, can we kind of see what caused that difference or why there was a discrepancy there? And I don't know whether using one criteria might help reduce that versus the other. I guess I would have to go back and look and see if we had a fasting glucose. We usually, for moms that are at higher risk of gestational diabetes, we can do that early screen and seeing whether there's any correlation there, that even if they pass their first one, they maybe barely pass their second one, or kind of comparing that, but have to go back and look.
And that, not all macrosomia is diabetes related to.
True.
Maybe it is and we don't know.
What you're saying is there's no gold standard, for diagnosing that, is really.
Right, yeah, gestational diabetes doesn't have a gold standard.
Perhaps tracking the A1C would be a.
Yes, so it's about tracking the A1C might be a good way, but certainly cultural, or not cultural, but just different nationalities, different body habits can contribute to large babies as well, and it's not always just gestational diabetes.
Can I just ask that clarifying question?
Sure.
So study 2 did show all of these combinations were statistically significant?
No, so for sure it showed that the MI only group was statistically significant. It was a little bit hard to tell whether they had that, I think it was in comparison to the placebo versus the, so not comparing like the inositol to the D-pyroinositol, the different interventions. Sorry, Dr. Ganser asked whether all of the different groups were significant or just the inositol was statistically significant. way different in the second study in the slide that you can see. So yeah, I had a really hard time discerning in the tables what they were comparing it to, if it was just the control or a combination of the control and the others. But certainly I can see that the percentage in the myo-inositol group was lower than the others, and definitely from the control. So.
I would think if that's a different group, that it would be in comparison to the control, just by definition, that this is control group, what you're comparing it to.
Right.
And then in the first study, it was only similarly, it was only the MI, but not inositol in general, just the MI subgroup.
No, that was really good. That's a roller coaster. Okay, it's break time again. Just a quick announcement and reminder, for those who are attending this evening's functions, there will be snacks but not dinner. So now's a good time to be thinking about your dinner plans, right? Because it's not going to be to show up and expect dinner. All right, so we'll get back here in 10 minutes at 2:18. Be free. You're free. Thank you. Up next, we have Dr. David Winston sharing more OB topics with us.
All right, the title of my topic.
Sorry. It looks like the title of your research project on our little sheet is...
It's Daniel Herman's.
Anyway.
Yes. The true title of mine is Does Planned Cesarean Delivery Lead to Better Outcomes Than Planned Vaginal Birth in Pregnancies with Breech Presentation at Term? Kind of an outline for this, I want to start with giving a review of breech delivery vaginal technique, and then discuss the research comparing the statistical outcomes of vaginal delivery versus cesarean delivery for breech presentation, and then finally critically appraise the data to determine how we can make the best, most appropriate clinical application. So starting off with the review of breech presentation, this happens in 3 to 4% of all pregnancies. We have frank, we have complete, we have incomplete deliveries. The difference in these presentations and a normal cephalic presentation is when you have head pressing against cervix, sometimes you'll have that emphasis cause cervical dilation and help with that process. When you have CPD and that head can't engage as fully, often you don't get complete dilation. And that ends up being a big concern, especially with this incomplete presentation when you have a footling presentation, because you don't have that equal surface pressure on the cervix to help with your dilation. So as far as how you deliver it, this is a complete breech presentation where the buttocks is coming out first. You want to grab the feet and you want to orient baby so that the back is facing up. This is going to help you a little bit later with flexion of the head to get baby out. It's really a hands-off approach for much of the beginning of this, where you don't want to touch the back in particular because you don't want to stimulate baby because baby might aspirate. You can't put your thumbs kind of right there on the sacrum and put some downward traction as well to kind of help baby come out there. And then you've got to release the shoulders. You often do this by twisting and kind of corkscrew baby's shoulders out. You can take 2 fingers in and sweep out one of the arms, and then you twist the other way to get the other shoulder out. One thing you've got to be really careful about is not to put too much torque on baby as you're doing this twisting motion. This is where you can get your brachial plexus injuries because you're stretching that head and neck if you put too much torque. And then finally, we have to get baby's head into flexion and get it underneath that pubic symphysis. And so you can have one of your assistants give some fundal pressure. You can also take 2 of your fingers and kind of flex the head down to facilitate that. If needed, if you didn't have that full cervical dilation, as I alluded to, you can cut incisions at 2 and 10 o'clock on the cervix itself to help deliver. The reason you choose these 2 locations in particular is because the cervical branches of the uterine artery are more laterally located and you really don't want to cut over those. You can also cut at 6 o'clock if needed, and obviously this will all need to be repaired at the end of delivery. And this is a diagram kind of showing you the whole maneuver with a slight variation. This is the Burns-Marshall maneuver. Once again, you kind of want to let baby's body hang there in the beginning. Take off the edge of the bed, or if she's at a table, she's sitting on the very edge of it so that gravity can be helping you. Once you see the nape of that neck, you give that downward traction, then flex the head, flip over onto mom's abdomen. Makes it look easy. So let's take a look at the review of the research regarding this. Do we have better outcomes with planned cesarean than vaginal delivery in this complex presentation? So the first statement is severe neonatal complications are increased when term breech presentations are delivered vaginally rather than by elective cesarean section. This was a 2017 cohort study. The N was 864,000. It was in the Journal of Maternal, Fetal, and Neonatal Medicine. And they looked at the Swedish birth registry, just at all their births from years 2001 to 2012, and compared the outcomes of those with breech presentation at term, whether they were vaginal or cesarean delivery. And if you look at these columns of the absolute risks, you can see how they're increased in the vaginal delivery group. For brachial plexus injuries, you've got 6.3 versus 0.3 out of 1,000. For your low APGARs at 5 minutes, You have 49.6 rather than 4.2, comparing the vaginal to the cesarean section. For neurologic morbidity, you have 5.7 versus 0.9, and then perinatal mortality, 4.6 versus 0.6, 7.6 times higher if it's a vaginal delivery rather than cesarean. There were some key limitations to this study, though it lacked information regarding how the route of delivery was determined. Were these women pre-selected and viewed as good candidates for vaginal deliveries, or did they just come in? Could they have been a footling presentation or a horrible candidate? We don't know any of that information. The cause of neonatal mortality also wasn't available in the registry to know, did it really result from the delivery method, or was it from some other unrelated complication or just genetic factor with the baby? And then finally, the data was limited to Sweden. Therefore, we have a different body habits of patients, medical training of providers may be different compared to other countries. Then the next statement, strength of this recommendation is grade A from a meta-analysis, and that's planned cesarean section for term breech presentation is associated with decreased perinatal morbidity and mortality compared to vaginal delivery. However, the absolute risk is low with vaginal breech delivery, supporting shared decision-making with each patient. This meta-analysis was from 2015, compared 27 articles. It had a large N as well of 258,000. 23 of the studies were retrospective, 4 of them were prospective. The majority were observational studies with 1 randomized controlled trial, and this data was collected between 1993 and 2014. 20 of the articles were from Europe, 2 from Australia, 2 from Asia, 1 from the US, 1 from Trinidad, and then there was 1 multi-country study as well. And comparing all of these, 17 of those studies supported careful selection of candidates for the vaginal delivery as being an acceptable option. 10 of those studies, their final conclusion was that routine elective cesarean delivery was preferred due to higher safety. Then looking at the data again, looking at your birth trauma, 7 versus 1.7, comparing the vaginal versus cesarean. At the low APGARs, 24 versus 3 out of 1,000. Same with neurologic morbidity, 7 versus 1 out of 1,000. And then perinatal mortality, 3 out of 1,000 versus 0.5 out of 1,000. But you'll notice it's still a relatively low absolute risk, 3 out of 1,000. And then neonatal asphyxia, 33 out of 1,000 versus 6 out of 1,000. There are some limitations in this meta-analysis as well. One of them was that the majority of these studies were retrospective and observational, so that increases the opportunity for bias. There's a large variation in sample size among the studies as well, which may underrepresent the results of smaller studies because they just pulled everything together to come together with the relative risk. So some of the smaller studies may have been way underrepresented compared to a very large study when conglomerated. And then all but 3 studies were from high-income countries. So subsequently, they may not be reflective of outcomes in lesser developed countries in comparison. And then kind of the third statement from the research, strength of recommendation B from a Cochrane review, is there's a decrease in perinatal and neonatal death for planned cesarean section compared to vaginal delivery for breech presentation. However, there is an increase in maternal morbidity associated with cesarean deliveries. This Cochrane review was from 2015. The N was 2,396. 2 of these trials were in the US. The third trial was a multi-country trial. Looking at this data is interesting compared to the rest. The perinatal mortality, once again, increased in the vaginal group, 11.5 out of 1,000 versus 2.6. The birth trauma also increased in the vaginal group, 14 versus 6 out of 1,000. But interesting enough, when they looked overall, the death or neurodevelopmental delay at 2 years old, there really wasn't that significant a difference between the 2. And it was actually slightly higher in the C-section group, 31 out of 1,000 rather than 28 out of 1,000. As would be expected, looking at maternal outcomes, there was increased maternal morbidity as well as pain after 3 months in the C-section group, as you would imagine. Of note, looking at these studies, a decrease in neonatal death and severe neonatal morbidity for planned cesarean delivery was evident in those trials conducted in countries where there was low national perinatal mortality. However, this reduction was not reflected in those trials in countries with higher national perinatal mortality rates, which was interesting to note. And there are some key limitations to this study as well. There was suboptimal randomization in the two trials. There was no blinding to the intervention, obviously. And there were some significant noted design limitations in 2 of the 3 trials as well. And then looking at the publication dates, these are relatively older studies from 1980, 1983, and 2000. Although the authors did search up all the way to 2015 for data to include. And this is an extra article I didn't mention in my formal FPIN. This was an observational perspective study with an intent to treat analysis. The unique thing about this is it was done from France and Belgium, and these are 2 countries that routinely did vaginal breech deliveries, and so their providers were familiar with this practice, and it was very common in these countries. And in this unique setting, their N was 8,105, they saw no significant excess risk associated with planned vaginal delivery compared with planned cesarean. In centers where the planned vaginal delivery was common practice and where strict criteria was met in these cases. That strict criteria would be assuming that there's normal pulvimetry for the mother, so we expect baby will be able to pass well. That there's no hyperextension of the fetal head as well, and that's important because you want to make sure the baby can get under the pubic symphysis. That the fetal weight was between 2,500 and 3,800 grams, so that baby would not be too large. That it would be a frank breech presentation. Once again, you don't want that footling presentation. You want to have an equal surface area against the cervix. And then obviously that they would have fetal heart monitoring and patient's informed consent in order to be in this group. Looking at their numbers, for the birth trauma, it was increased in the vaginal group, 17.9 versus 4.6. Lower APGARs under 7 at 5 minutes was also increased in the vaginal group, 14.7 versus 4.7. Then look at that perinatal mortality. Is interesting. In their particular study, it was actually higher in the C-section group, 1.26 out of 1,000 versus 0.7 out of 1,000. And so what do we make of all this information together? It's easy to just look at hard facts and data and say, just tell me the evidence-based answer, that's what I'm going to do. I think there's a lot of complexity to this issue, and you really have to consider multiple factors, and it takes wisdom and discernment to know how do you apply this in context with your patients, with your setting. So first, I think it's important that we recognize a relatively low absolute risk for vaginal breech delivery. There is increased risk, but 3 out of 1,000 in that one study still is not as that high. Discuss how many children the mother is wanting. What are her wishes? If she's a new mom, this is her first child, maybe she doesn't want a C-section if she wants a larger family. And that's something that's important to play in and factor into this decision. Obviously, it's important to offer external cephalic version. This is why we try to make sure that baby's cephalic when we're getting to that 32 weeks or so. Make sure that we catch things early to know, do we need to offer them ECV so we can flip baby and try to get a cephalic delivery. Then you have to consider the experience of the delivering physician. This is a harder thing in the US now because there are very few physicians that will do breech deliveries. There's still midwives that do it, but it's very rare to find physicians that have the skill, the ability, and the hospital privileges to do these deliveries. I think the real important factor is for those of us considering going overseas, how do we apply this? Because there are unique considerations in other countries that we might not deal with here in the US. The skill of the individual performing the C-section overseas, many times it's people who may not be trained as well in C-sections, and their risk might be much higher. What's the sterility in their operating room? How is their technique? How is recovery from the C-section? What are the local risks for the perioperative complications? What's the expected activity during recovery period? It's easy for us to tell a woman here in the US, no heavy lifting for 6 weeks, keep your wound clean. We glue it so that infection doesn't happen there, hopefully. But when you're overseas, you're not gluing over that incision site. A woman can't not lift something heavy for 6 weeks. You get a lot more wound dehiscence, you get a lot more infection, a lot more complications. In sub-Saharan Africa, maternal death from C-sections is 0.5 to 1%. So if you're talking about losing 1 out of 100 moms for C-sections versus 3 out of 1,000 babies in breech delivery, that starts giving you perspective. It's easy to say, cut the baby out, it'll be safer for baby, but we've got to take a step back and look at the overall picture, look at our context, look at our mothers, and these unique situations, and see how do we apply facts to the unique situations of our patients, and realize it's not a simple, easy answer per se. This is just a picture of me in Malawi, where I got to do obstetrics, and actually was able to do 4 vaginal breech deliveries there. One happened to be a footling as well, not by choice. And so just in summary, severe neonatal complications are increased. However, the absolute risk is low, and shared decision-making is very important in making these decisions. And then there is a decrease in perinatal and neonatal death for planned cesarean section. However, you have an increase in maternal morbidity associated with the C-sections. That's a list of my references, and I'd like to thank Dr. Ledbetter as well, who is my excellent advisor for this session. Any questions? Yes.
I have one from Health Plaza, two. The last study that you mentioned was an intention to treat study.
Yes.
And so the question is, what percentage of the planned vaginal deliveries ended up with a C-section?
That's an excellent question. I would have to look back to know the exact number. I'm afraid to give this figure because it might be wrong, but I want to say about 30%, maybe. But I'd have to look back to check.
The second question about that was, why do you think the mortality was higher for C-sections in that particular study? And could it have been, I think the inferences could have been because of the failed breech of the C-section.
Possible. I think part of it is, in general, we're looking at neonatal mortality numbers that are low. Look at your N, it's 8,105. And so how many babies are dying out of that? And so if you get 1 extra baby, it kind of skews things a little bit because we're looking at low absolute risk numbers. So part of it is just a byproduct of the N and the low incidence. And so that can make it challenging. Also, this topic in general is not very conducive to randomized control trials in general because there's so many variables in it. But I think this is an excellent consideration that if you plan for it and you have skilled providers, that it could be a very viable option.
You said you had 4 of them in Malawi?
Yes. Yeah.
All 4 babies do fine?
All 4 did fine.
Because you did the also course.
And there's a set of twins, so 2.5 kilo, 2.7 kilo baby. The largest was a 3.8 kilo.
Yeah, so this is the last one, so exciting. Yeah, I imagine that everyone is exhausted, but yeah, my name is Grace Yoon. I'm one of the second-year residents here at I.H.I. And my FPing question is this: is iron therapy effective in treating restless leg syndrome? We see a lot of patients with this complaint, so I found this question clinically important. And my preceptor is my amazing Dr. Howard. So let's start with case discussion. 44-year-old male comes to the clinic complaining of urge to move his legs and uncomfortable sensation in his legs. You take good history and then diagnose restless leg syndrome. And according to the International Restless Leg Syndrome Severity Rating Scale, which is also called IRLS, his symptoms are moderate. Patient is otherwise healthy and is not on any medication. You suddenly remember someone mentioning iron therapy as one of the treatment options for restless leg syndrome. You review the patient's chart and you realize that he recently completed CBC at a local health fair 2 weeks ago. His hemoglobin was 13. You obtain ferritin level and the result shows 70, which is kind of normal range. Patient would like to try something because his symptoms have been so bothersome. What would you do next? So A, hemoglobin level is normal, so do not start iron therapy. B, ferritin level is normal, so do not start iron therapy. Start iron therapy. And start iron therapy only when non-ergodopamine agonists such as pramipexole or ropinirole or an alpha-2 delta calcium channel ligand such as gabapentin is not effective. So think about the answer and we'll get back to this question later. So first, let's start with definition. What is restless leg syndrome? So it is a common sleep-related movement disorder, and patient feels unpleasant or uncomfortable urge to move the legs when they're not moving, especially in the evening, which is temporarily relieved by movement. UpToDate website has a very good article that explains diagnostic criteria. Basically, we need 5 clinical features for definitive diagnosis. I can share that article later if anyone is interested in. And again, my FP question is this: is iron therapy effective in treating restless leg syndrome? And the answer is yes. Iron therapy is effective in reducing symptom severity of restless leg syndrome compared to placebo, with similar or less adverse effects. And IV iron and oral iron both have been shown to be effective. And why is this question important? Restless leg syndrome is a common disorder that's known to be associated with peripheral iron deficiency in a subgroup of patients, but it was unclear whether iron therapy is effective treatment. If it is truly effective, it'll be a good news to us because we commonly face this diagnosis in our practice. And iron treatment is pretty well-known medication that we can easily prescribe, and patients can even purchase them over the counter. So let's go over the evidence. A 2019 meta-analysis of 10 randomized controlled trials evaluated efficacy of iron therapy in reducing severity of restless leg syndrome. Total number of participants were 428. The experimental group received iron treatment either intravenously or orally, and the control group received placebo, except for a single study where the control group received pramipexole. So what was the result? Iron treatment led to a clinically significant improvement in symptoms compared to the placebo group. And 7 studies used International Restless Leg Syndrome Severity Rating Scale, simply called IRLS, to quantify the reduction of uncomfortable leg sensation. As you see here highlighted in the right corner, iron decreased the severity of scores significantly, more so than did placebo, with a mean difference of -3.8. So iron treatment resulted in clinically significant improvement in restless leg syndrome symptoms compared to the placebo group. And in the subgroup analysis, there were 3 studies that only selected those with low or low normal iron stores, as you see in the middle row. And studies in the lower row didn't select participants based on their iron status. The result was there was no significant difference between changes in restlessness between these 2 groups, as evidenced by p-value of 0.3 in chi-square analysis. So in summary, yes, there was no significant difference between changes in restlessness, whether groups were selected based on iron status or not. And those 3 studies in the middle row additionally reported that baseline ferritin levels were not different between participants who responded to iron therapy and those who did not. Then how about any adverse effects? Adverse effects were also compared between iron and placebo groups. Review of 6 RCTs with total participants around 300 demonstrated no clinically significant differences in adverse events between the 2 groups. As you see here, confidence interval of risk ratio including 1. And interestingly, GI side effects of nausea, vomiting, constipation, or abdominal pain, diarrhea were no more common in the iron therapy groups than placebo groups, as evidenced by confidence interval including 1. And also, so in conclusion, adverse events were no more common with iron therapy group compared to placebo group. But according to one study that compared between iron versus dopamine agonists, such as pramipexole, adverse events may be less common with iron than with a dopamine agonist. And this picture was taken during our ACT Bible course. I love this picture of our class with Dr. Danik, Dr. Williams, and Mrs. Williams. You all can see here how much our class loves Dr. Danik, fearlessly attacking residency director. So going back to our study, first we learned that iron therapy is effective in reducing restless leg syndrome. Then we can ask another relevant question. So what type of iron formulation should we give to our patient? 2018 clinical practice guideline by an international restless leg syndrome study group, in short IRLSSG task force, underwent systematic review of 31 papers to answer this. 6 studies investigated efficacy of IV formulation, and the participants were non-anemic adults with moderate to severe symptoms. And of the 3 RCTs, 1 RCT restricted study population to those with ferritin level less than 75 or ferritin less than 300 and TSEP less than 20. But the other 2 RCTs did not specify iron status as inclusion criteria. And all 3 RCTs demonstrated clinically significant improvement in symptoms. And also, other 3 open label studies also supported the efficacy of IV ferric carboxy maltose. So So based on these studies, the authors concluded that IV favorite carboxyl maltose 500 to 1000 milligram may be effective in reducing restless leg syndrome symptoms in non-anemic patients with serum ferritin level less than 300 and T-SAT less than 45. The limitation of this recommendation include a relatively small sample size of each trial and insufficient evidence to conclude long-term effects on these patients. And the efficacy of oral ferrous sulfate was also assessed in 4 studies. And 1 RCT evaluated non-anemic patients with ferritin range of 15 to 75, and IRLS score decreased significantly in those treated with oral ferrous sulfate compared to the placebo group. Another RCT also demonstrated clinically significant improvement in symptoms. And another open-label study also supported efficacy of oral ferrous sulfate. And based on these evidences, the authors concluded that oral ferrous sulfate 325 milligrams twice a day may be effective in decreasing restless leg syndrome symptoms when their serum ferritin level is 75 or less. Other iron formulation were also evaluated, but they are deemed either ineffective or inconclusive, so was not included in this guideline. So further investigation will be warranted in the future. These 2 algorithms are from 2018 IRLSSG guideline. So left side is algorithm for oral iron treatment, and right side is algorithm for IV iron. And there is also a pediatric version of this algorithm, but that is beyond the scope of our discussion today, so I didn't include it here. I like this algorithm because it is very specific and easy to follow. Several caveats that I want to point out here is, first, as we all know, ferritin level can be falsely elevated in the presence of acute or chronic inflammation. And secondly, as you see here in the IV iron algorithm, they specify ferritin level less than 100, and this is somewhat arbitrary cutoff. And why this is, although benefit may occur when the pre-treatment ferritin level is between 100 and 300, current data and experience are incomplete. So that is the reason why their cutoff is 100 here. So going back to our case discussion, so 44-year-old male here with restless leg syndrome. Patient is otherwise healthy and not on any medication. Patient is hemoglobin 13, ferritin level 70. What would you do next? A, hemoglobin level is 13. So why would you start iron therapy? B, ferritin level is normal. Again, why would you start iron therapy? C, start iron therapy. D, start iron therapy only ropinirole or gabapentin or Pramipex, so those are not working. So what is your answer? Answer is C. So ferrous sulfate 325 milligrams twice daily may lessen the symptoms, especially if patient's serum ferritin level is less than 75, which is low to low normal range. Thus, iron status should be evaluated in those with suspected or confirmed restless leg syndrome. So, yeah, these are my major references. And then big thanks to Dr. Howard and my king, Jesus Christ. Yeah, any question or yeah, any question? It's okay not to have a question. lender.
You said the only form of iron that worked was the iron sulfide, is that right? The other forms didn't work?
They evaluated other forms of oral iron, and then they were also effective, but some studies were inconclusive. So, to establish guideline, ferrous sulfate was more established and were more frequently used in most of the studies. So that's the reason why. Yeah, they recommended ferrous sulfate. Yeah, Dr. Rylander's question was if other oral iron form was also effective or not. Yeah.
So how do you know if it was the sulfur or the iron that was effective?
Oh, sorry?
How do you know if it was the iron or the sulfur that was effective? Sulfur is a homeopathic cure for restless leg syndrome for a long, long time.
Yeah. Oh, I think my hearing is so bad. So,
It's not in I.H.I. Fairlacid, so.
yeah. Sorry, yeah. I don't think I understood the question, honestly. So, yeah, sorry about that. Yeah. Yeah.
Well, one answer would be that if it was the sulfur in it, then the ferritin level wouldn't have mattered. And the ferritin level did matter. It only was effective if it was, like in the lower normal range.
Yes. So ferritin level was actually did matter when it was oral form, because if ferritin level is really high, then it's known to be like not absorbed effectively. So in that case, I think this guideline is recommending going to IV form rather than oral form. Yeah, and then Dr. Answer. Okay.
All right. Wow, we did it all in one day. I can't even believe it. Maybe this is a template for future summer retreats. Maybe not. Well, thanks to all of our second years. Your presentations were very good. Obviously, knew your topics very well, and I just want to give you all another round of applause. Okay, a couple of announcements for right now. If you could, before we dismiss, make sure that your trash, if you're not taking it with you, that it ends up in a trash bin. And then also, if a couple of people can help Reverend McVeigh, we need to transform this room for the I.H.I. board meeting that's going to be in the morning. So if a couple of you will stay back to help with that, that would be great. And for those who are in the back, if you're going to stay and socialize, either do so in the front of the room or move to the PWA or outside or just not in the back of the room. We have our fun run tomorrow, and that will be across the street at Helmert Park. There will be games and snow cones and winners and losers. No losers. So please be here. That's going to start at 8 a.m. and then I believe Josh's snow cone will be here at 8:30. Yeah. Alumni, make sure to fill out your CME forms, both if you're present and then online as well. For those who are residents, please turn in those forms so that we can check your attendance. And the link for those of you who are live streaming tonight and won't be there in person, the link to that live stream is on the IHIretreat.com webpage. And then finally, our judges. A few of you didn't have to be here today, but you were anyway. So thank you for your time. I really appreciate that. Judges are going to be meeting once we finish here. If you would, in the front part of the room where Dr. Perry is, that would be great. I believe that's it. Any other announcements to make?
We probably need to help Hannah with some of this electronic stuff. So who's ever good at that?
No, don't touch that.
Don't touch the electronics is the announcement, especially if your name is Dr. Dunnick.
There are things that you can help me with, but please don't touch those stuff.
Don't touch the electronics, but help Hannah. Okay.
I love that idea.
All right. All right, let me close this in prayer and then we'll dismiss. Lord, thank you so much for today. Thank you for renewing our minds with new knowledge that is from you. Lord, we thank you for this evening and just continuing the celebration of this academic year. And yeah, we just praise you for your work here. In Jesus' name, amen.
Amen.
Bye, guys, in the health closet. And around the world. Judges.